Well, it's good to see so many people back out here this morning. I'm your moderator. I'm Dr. Wayne Tuckson. I'm a retired colon and rectal surgeon, but we are talking about kidney disease. So don't get worried. I won't be doing any free rectal examinations or anything like that. However, if you bend over and I happen to be behind you, run, run. But to all of you here at St. Paul Church of God in Christ here in Milwaukee, and to those of you joining us virtually, I wish you a good morning and welcome back to part two of our program, Protecting Health Equity in Kidney Care, a community conversation ensuring access to life-saving end-stage renal disease, oral-only medicines within Medicare. This program is hosted by the Calvary District Church of God in Christ, Superintendent Walter L. Fields Jr., and District Missionary Evangelist Ora McGahee, in partnership with Heal Collaborative and Artilex Pharmaceuticals. As we heard yesterday during part one of the program, African Americans are 3 times more likely than whites to suffer from end-stage renal disease. And when they do have early stage kidney disease, are more likely than whites to have treatment to decrease their instead, less likely rather to have treatments that may help prolong or slow down the advancement of disease than their white other patients. We also heard that there are disparities in the medical and surgical treatments of patients with end-stage renal disease, unfortunately, along racial lines. Today, we're going to hear about the personal journeys of patients with renal disease. Then we will have an in-depth discussion on the risk, causes, management of symptoms, and treatment of renal disease. Following this, we'll have a slight pivot into a discussion on what those of us with and without renal disease can do to affect policy that will impact the treatment of patients with end-stage renal disease. While this discussion is going to be specific to patients with renal disease, the topics discussed will be germane to other illnesses and other afflictions within our community. At the conclusion of the presentations, we're going to have a question and answer session. So I encourage those of you here and those of you who may be joining us virtually to think about questions, write them down, and ask them so that we can answer your questions and also provide further clarifications. I promise you, any question that you may have, someone else is probably thinking it also, so it's going to benefit us all. We will conclude today's program with a call to action in which we can find out what are the things that we should be doing to help ourselves and those other folks in our community. But first, let us begin by having a welcoming and a prayer from Superintendent Walter Fields, who is the senior pastor here at St. Paul Church of God in Christ. St. Paul. Please make note of it. I said St. Paul this time.
Thank you all again for assembling here this morning. We had a wonderful time of sharing on last evening, and so informative in the area of chronic kidney disease. I was sharing with some just earlier today that the information that I received personally was very enlightening and educational. And so a lot of times we fail to come to settings like these, but information is important. If we were able to come and gain knowledge that would be a benefit not only to ourselves, but to others, it helps us to be impactful in the lives that we live daily. So, with that being said, I want to just pray a prayer this morning, and then we will move into our dialogue. God, our Father, we are grateful again for this time of sharing. We thank you, dear God, for the ability to come into this setting and to gather information again that will be helpful to our lives and instrumental in our growth. We pray to God that you would touch those that are presenting today and give them wisdom and insight, give them greater intellect, God, that they will be able to convey a message of hope, a message of health, and a message that will benefit the lives of those that hear. We pray for even those that are here for information. Open up our understanding. Give us to receive what's being spoken today. And then give us the wisdom to apply the knowledge that we apprehend so that we can live lives that are healthy and lives that are beneficial and impactful to others that we encounter. We pray these things in your Son, Jesus' name. Thank God and amen.
I'm always impressed with the leadership from the pulpit. And I noticed yesterday, everyone was sharp. And I noticed this man is of sartorial splendor beyond words do not describe. I don't know if Mr. Kevin Daniels has made it here yet. Okay, we will move on. So the first person which we're going to hear from today is Judge Derek Mosley. He is a patient with end-stage renal disease. I'm sure all of you are familiar with Judge Mosley. You've probably seen him decked out in his fedora and his black robe, which he ain't got on today, but doesn't need it because we know what the brother looks like. Judge Mosley is a native of Chicago. After getting his undergraduate degree at the University of Iowa, he then attended Marquette Law School. He then served as a prosecutor and then spent 20 years on the bench in the Milwaukee Municipal Court. 10 of those years, he was the chief judge. That's something else, man. Since stepping down from the bench, Judge Mosley is now the director of the Marquette University Law School's Lubar Center for Public Policy Research and Civic Education. You know, and his stature on the bench is well known to all of you all. But I think the most impressive thing is the man's a foodie. He knows his food. And to that degree, in 2022, he served as a judge for the James Beard Foundation as one of the food judges. I think that's cool. So, Judge Mosley, please tell us a little bit about your story.
Doctor, thank you. Pastor, thank you. Good morning. As mentioned, my name is Derek Mosley. I am, as also mentioned, I'm the director of Marquette University Law School's Lubar Center for Public Policy Research and Civic Education. Today's a special day, not only to be here to speak to you because I was diagnosed with chronic kidney disease, but it's also another special occasion for me because 8 years today. Today is my 8-year kidney anniversary from my kidney transplant. So, just to tell my story real quickly, I have a history of kidney disease in my family. My grandmother was actually the first person to have a kidney transplant at Rush Hospital in Chicago. At the time, it was called Rush Presbyterian St. Luke's, but now it's just called Rush Hospital. That was back in the late 60s. And my father actually passed away on the list waiting for a kidney. Every day, 12 people die on that kidney list waiting for a kidney. Um, so I'll just give you the story briefly. So I was on the bench, I was a judge on the bench. And before, uh, when my trials were about to start, I went into my chambers. And in the chambers, every judge has their own bathroom in the chambers. And so I had just urinate in the bathroom. So I went to the bathroom. I got out of the bathroom, I left, and my bailiff walked in after me and went to the bathroom. And when she came out, she said, "Did they just clean your toilet?" And I said, "No, no, no, no one's cleaned the toilet." And I said, "Why'd you say that?" She says, "Well, because it looked like there was some kind of cleaner in there because it was all foamy in the toilet." And I said, "No, I was just in there." And she's like, "You created that much foam?" And I was like, "I guess I didn't know." And she's like, she said something. She said, I had a grandfather who had some kidney problems, and he had this condition where he created a lot of foam in his urine. You should get it checked out." So I called my doctor and I set up an appointment. And I went to, it was like, he got me in the very next day. So I went to the doctor before court was supposed to start. I had to just give a blood sample and a urine sample. I did that. I went to court. They wrapped me in. All rise. I walk out. My phone goes off. If any of you are part of the Freighter health system, if you see a 805 prefix, it's a good likelihood that it's going to be freighter. So I saw the phone said 805. I figured I just left the hospital. Something must be wrong. I go back and it's my nephrologist. And my nephrologist says to me, "We did your blood work. Your creatinine is really high. You have a double digit creatinine." And so my creatinine was in like the 12, 13 number. It should be like 1.4, 1.3. It was like 12. He says that you have a lot of uric acid in your blood as well. And we think there's a number, it's called the GFR. And my GFR number was extremely low. It was dangerously low. So he said, come back in, we'll do a few more tests. We do a few more tests, found out that my kidneys were functioning at about 12%. And I really didn't have any outward signs of it, so I really wasn't that aware of it. Nothing that you wouldn't think was fatigue that from working as a judge, you do your job working, and then I taught and I did all these other things. I coached my daughter's basketball team, so I just thought I was just tired just because of all the things I did. And then they said we need to fit you for a fistula because you have to begin dialysis immediately. And my doctor, the reason why I had this nephrologist is because he doesn't sugarcoat anything. And that's why I picked him. And he said straight up, if you don't get a kidney, you are going to die. And so that hit me hard. So I got the fistula, which I still have today. Um, and I started dialysis. Now, because I was a judge and I had court every single day, I couldn't do your normal dialysis where you would go into a center, you go there 3 days a week, you're there for 4 or 5 hours. I couldn't do that because my court calendar wouldn't allow me to do it. Not to mention the fact they wouldn't want me to do it because without my job, I wouldn't have had insurance and they wouldn't have paid for my dialysis. So I did what's called peritoneal dialysis, and it's the type of dialysis where they inject a bunch of fluid into your body, and you get bags of fluid, and that fluid goes through and picks up all the impurities, and then it flushes it back out of your system. I did that every day for 10 hours a day. So I got a machine, had it brought to the house. I would go to work, come home from work. I would eat dinner with my family, which was the only time I would see them at that point because I would go upstairs to my bedroom, hook up to the machine. I would be on that machine for 10 hours. And then in the morning, unhook myself and then go to work and repeated that process over and over and over again. Did that for 10 years, did that for 2 years, 10 hours a day, and only missed one day. And the only reason I missed that one day is the woman who would ultimately become my kidney donor. Her son was getting married and we were flying to go to the wedding, and I forgot one piece of the dialysis machine. And that wedding it was in northern Wisconsin, so it was about 6 hours from here. It was in the middle of nowhere, out in the forest somewhere, and so there was no way for me to get that piece. And so it was the only day I missed in the 2 years of the dialysis. I did it religiously, and when you're on dialysis, your life changes dramatically. It changes in the way that things that you normally would do, that people would do every day, you weren't able to do. Not to mention you had to limit your water intake and things of that nature as you were on dialysis. So I did that. And then when you're a judge, you go to, a lot of people don't know this, you go to a place that's in Reno, Nevada. It's called the National Judicial College. And all judges who are elected are sent out to this college to learn how to be a judge, right? How to put on the robe, how to do all this other crazy stuff. So I went out to Reno, and while I was at Reno, I met a woman who was also a judge in Wisconsin, but we really didn't know each other. And we were talking and became friends. And then when we come back to Wisconsin, I finally tell her, I said, hey, I'm in this situation where I have to have a kidney transplant. If I don't have a kidney transplant, I'm going to die. And she says, well, you can have my kidney. I mean, just said it just like that, like I was borrowing sugar or something. And I said, well, you're really sweet. I appreciate you saying that, but we're completely different, and I'm not quite sure that your little kidney is going to work in me. Like I said, I'm black, you're white, male, female. I'm a big guy. She's really little. I'm like, I don't think your kidney's going to work in me. And she says, well, let me get worked up and just see if we can do it. So we do that. She gets worked up. And when she gets worked up, she comes back a perfect match. Now, when I tell you a perfect match, this is how perfect. She has 2 children. She could not donate to either of her 2 children if they needed a kidney because they share her husband's blood type. She shares my blood type. And so she was a perfect match for me, but not for her own children. So just put that in perspective. So I still don't think this transplant's going to work just because of our differences, our sizes, and everything like that. And so we do the surgery. The surgery takes place. Normally, when you wake up from surgery, you come out of anesthesia, and your family members are in the room, but they're like on their phones or something because they don't know where you're going to wake up. But when I woke up, the doctor was over me, and it kind of freaked me out because I figured something was wrong. And I said, "It didn't work, right? It didn't work." And he said, "No, no, it worked. We were just waiting for you to wake up." Because I'll be honest, that was the best sleep I had in my life. So, and he said, "We're just waiting for you to wake up." So I say, "Doc, I can't believe this worked. I mean, we're completely different. Black, white, male, female. I'm a big guy. She's little." And he said something to me that I will never, ever forget. He said, "I had your kidney in one hand and I had her kidney in the other hand, and I couldn't tell them apart." And I was like, wow, wow. But you did tell them apart, right? I want to make sure that make sure we got that part straight, right? So um, we had the transplant on July 20th, 2016. And as I mentioned, today is our July 20th, 2024, which is our 8-year kidney anniversary. I'm leaving here. I have to officiate a wedding, and then I'm taking her out to dinner for her gift. Um, but I wanted just to come because I did a lot of research. I'm a lawyer. And so as a lawyer, I did a lot of research. And there was a study that I'm not quite sure was getting a lot of traction when it comes to kidney disease in African Americans. And the study was trying to see this correlation between slavery and kidney disease. And what this researcher had opined was that um, the individuals who were taken from West Africa and brought over here in the Middle Passage, that journey was a 3-month journey by boat, that he opined that those individuals had to be natural salt retainers. And he said, as natural salt retainers, that is the reason why they made that journey shackled in the bottom of a boat, not a lot of food, not a lot of water, that the people who made that journey and survived that journey, he opined, were natural salt retainers. And as a result, when they got here, they, of course, um, had children with other natural salt retainers. And he said, and you couple that with the diet, which at the time was a slave diet, but we now call soul food, things with high salt intake, um, things that greasy, things high fat content, things of that nature. And we couple that together, that he believed that that was a reason why so many African Americans had this high incidence of kidney disease. Now, I don't know if that is true. I read a whole bunch of crazy stuff, but it makes sense to me. It does make sense to me because when I was doing dialysis and I sat in that chair, you sit in the chair. I started off doing dialysis in a center where you're in a chair, you have your own machine, there's like 30, 40 other people with you, and you just sit there and you watch one TV. And of course, I told you I was a judge, and I sit there and there's one TV, and everybody wanted to watch Judge Judy. And I was like, you got to be kidding me. So we just sit there and we're doing dialysis. And I looked to my left, I looked to my right, and everybody looked like me. And we ran the gamut from age, from as young as 18 all the way up to 70, 75, 80 years old, all on this in this room doing dialysis. So I'm not a doctor. I don't know the medicine, but I know a lot of people who look like us are getting dialysis and are waiting for kidney transplants. On a side note, even though we are only a small portion of the population, we make up almost half the people waiting for a kidney for kidney donation. Now, despite the fact that we make up almost half the people waiting for a kidney for kidney donation, we also represent the smallest number of people who have listed themselves as donors for kidneys. And so we are on the list as the highest group that needs a kidney, and we're the lowest group that's willing to donate a kidney. So I come with a number of messages. One message is please take care of yourself. My dad was the kind of, and my uncles and most of the black men I grew up with in my lives were the type of men who didn't go to the doctor all the time. It actually didn't go to the doctor at all. In fact, when they went to the doctors, it was already something wrong with them. But preventative care is the key, is the key. And that's the one message. One message that should tell you to please take care of yourself and to watch what you eat. Um, and exercise, things of that nature. In fact, I was on a walk, that's why I'm dressed like this morning. Secondly, think about becoming an organ donor, putting that sticker on your driver's license. We have organs. God saw fit to give us two. One was a spare. You only need one to survive. And so whenever time I hear a story of someone who's passed away and wasn't an organ donor, I just think of the gift of life that could have been given to someone else who was waiting for that kidney. It hits home for me because, as I told you, my father was on the wait list for a kidney and actually passed away before he was able to obtain a kidney. So please do those two things. It's important for all of us. There's a quote my mom used to tell me, and I had it on my bench every day. I would look at it every day when I was on the bench as I did my court cases, and I have it in my office now. But the quote was, "To the world, we're just one person, but to one person, we could be the world." And so, please consider thinking about organ donation. Please consider spreading the word about organ donation. And as I mentioned, I couldn't think of a better place I'd rather be right now, my kidneyversary, than here talking about kidney disease and kidney donation. So, thank you very much.
Oh, yeah, yeah. Yeah. Thank you very much, John. I appreciate that. You said something I think that was very important for us to hear. Uh, you said that you could not afford to take the time off to go and see somebody because you needed the job to pay for. So
Yeah.
two questions I would ask.
Before you say that, just I gotta tell you this, 'cause I kept it. I kept it just because.
Okay, okay,
I
I'm glad to hear that.
so when I my kidney transplant was over, I got my kidney bill, and I actually have it framed in my office. My kidney donation, my kidney transplant
Mhm.
was $993,000. Just to put that into perspective, 993,000. I had never seen a medical bill like that, so I framed it because I thought I'd never see one again. Just to put it into perspective. So
Okay.
yes, no, I would not have been able to
So,
afford it.
so you raised two, but the points you raised, I think, are pretty interesting. Number one is how many of us are in a position where we can't afford to leave our job because our insurance is tied up, and what impact does that have as you talk to some of the other
Yeah.
patients? And yeah, so answer that one for me first.
Yeah, so that one's easy because I that's the reason why I chose peritoneal dialysis over hemodialysis. Most people are familiar with hemodialysis. I started on hemo. That's when you hit the fistula and you are on a machine. It takes your blood, it cleans it, puts it back into your system. That's the dialysis most people are familiar with. Peritoneal dialysis is the type of dialysis where they put a tube into the peritoneum of your stomach and you get this fluid. The fluid is basically sugar. And they put this sugar into your body, it collects all the impurities, and then it cycles it and puts it out into bags after you're done. Um, the only reason I did peritoneal is because peritoneal allowed me to keep my job. Otherwise, I have to apply for disability or not be able to.
But put that in perspective now. So you're a judge sitting on the bench. You've got control of your time. Let's talk about the person who may be a laborer or who has some other job. But how feasible? And we're going to hear more about this
Yeah,
from Dr.
yeah.
Jose later on. In fact, you've made her job easy and hard. I'm saying that what you've already talked about. But tell me about is this when we talk about peritoneal dialysis? Is that something that everybody can do,
Yeah.
or do you have to? And what kind of resources did you have to devote to having peritoneal dialysis versus going for hemodialysis?
Yeah. So the good thing about right now, the good thing about people who have chronic kidney disease and are need a transplant or on that path for a transplant has to do with Medicare. So I immediately was put on Medicare as soon as I was on the list to get a kidney. And by being placed on Medicare, that took care of all the cost of the dialysis that you might incur. And dialysis is expensive. I mean, the transplant is almost $1 million. Uh, but dialysis, every time you sit down in that chair, that could be anywhere from 30,000 a session, and you do it 3 days a week, every day for the rest of your life until you get that transplant. So Medicare allowed me to pay for the dialysis, and the options are there. If you have the ability to take 3 to 5 hours out of your day, 3 days a week, and do the dialysis, you could do hemo. If you have the ability to stay at the hemo center, you could stay there. They have beds where you can sleep there all night and do dialysis overnight. Um, Medicare also would pay for the ability for you to bring that machine into your house, which is what I did. I had the machine brought into my house so I could do dialysis at home because I had two little girls and I wanted to at least be able to spend time there with them while on dialysis. So there's a ton of options for people on dialysis. Now, um, dialysis was my biggest fear. But when I found out that I had end-stage renal disease, the first thing I said to my doctor was, please tell me I don't have to be on dialysis because all I heard about stories about dialysis. Now, and dialysis is not glamorous or anything like that. I'm not trying to tell that to you. It's not. It takes up a lot of time. It's draining, but it's a lifesaver, and it's the best we have right now. And tell you, it got me here to where I am before you right now because without dialysis and without that transplant, I definitely would not be here.
I know you got to run, Judge. I want to ask you one other question, though.
Yeah.
One of the things we heard a lot about yesterday was patients having hyperphosphatemia, having elevated levels of phosphate,
Mhm.
and needing to take multiple pills. Can you tell us what is it like taking the pills that you have to take with your renal disease
Yeah.
and how much fun that was?
Yeah, how much fun it is. So yes, the phosphorus is huge. When you get kidney disease, your phosphorus starts to go through the roof. And so there's a lot of things that you can't eat because they're high in phosphorus, like cucumbers, tomatoes, things of that nature. Now, what's interesting now, after my transplant, my phosphorus is now low. So they're like telling me, eat as much tomatoes, eat as many cucumbers as you want, which is great because I love both of those. But um, yeah, the pill thing is something that was new to me. So once you were immediately done with the transplant, I was probably taking around 22 pills. And now I'm down to like 14 or so. And you might think that's a lot, but I just it's no big deal. When I first did, I would take one at a time and drink it with the water. Now I'm just like, ugh, just get it over with. Um, but yeah, the pills. But like I said, and they said you'll be taking those pills for the rest of your life. I will gladly take those pills for the rest of my life, then get back on dialysis. So yeah. I really want to thank all of you for allowing me to come here to tell my testimony because I just hope if I could just reach one person and you could reach one person, then we can get that list knocked down. As I'm speaking to you right now, or while I spoke to you right now, somebody died waiting on that list for a kidney. Just while I was talking to you in this little time that we were talking, and 11 more people will die before the end of this day. So thank you very much. Yeah, to the world, you're just one person, but to one person, you could be the world. Thank you all.
Well, that wasn't the least bit inspiring, was it? So, what was it like when you're sitting up there on the bench and you're looking down at people, man? All right. Hear ye, hear ye. With that setup in mind, and to give us a better understanding of the clinical presentation, diagnosis, and treatment of renal disease, we have as our next speaker, Dr. Mukoso Oze. Dr. Oze is a graduate of Nnamdi Azikiwe University in Nigeria. She completed residency in internal medicine at the Wright State University in Dayton, Ohio, followed by a fellowship in nephrology, and then obtained also a Master of Science degree in clinical research, both at the Medical University of South Carolina in Charleston, South Carolina. She is currently an assistant professor of medicine in the Division of Nephrology at the Center for Advancing Population Science at the, is it Froedtert? Froedtert, that's what he was saying, Froedtert. I must have not encountered that word, and I hope I never see it again. Froedtert and Medical College of Wisconsin Health Network, and at the Clement Z. Zablicki VA Medical Center. She has several, which I'm impressed by this, several NIH grants. And for those of you who don't know, that's like at the top of stuff that you're doing. So if you got an NIH grant, you cooking with gas, or as we say down south, you in tall cotton. So she's doing real well with that one. I'm glad to hear that. And her research focuses on the interplay of social risk factors, lifestyle, and genetic risk factors in African Americans with chronic kidney disease and diabetes. Today's topic is understanding chronic kidney disease, risk factors, and kidney failure management. I give you Dr. Ozeye.
Yeah, as, as I can relax. Yeah. Yeah. So I'm happy to be here, and thank you, Judge Mosley. He's not here, but he made my job easy. Maybe not. But hopefully I can provide some more insight into understanding chronic kidney disease and kidney failure management. You can advance the slides. So these are a few objectives. So we'll kind of review what the kidney does, and then talk about chronic kidney disease, then talk about how do we diagnose chronic kidney disease, what are the causes of chronic kidney disease, the risk factors, and then what are the symptoms of chronic kidney disease. And then we'll talk about the management of chronic kidney disease and kidney failure. And then I'll also talk about a few research programs that I have going on right now. So who am I? So I'm a physician scientist. So this means that I spend half of my time, um, maybe less than half of my time, taking care of individuals who have chronic kidney disease, whether in the clinic or inpatient. So I also see patients at the VA, and then at Freighted, I have a clinic. And then the other half of my time, I also spend doing research. And my research is really focused on chronic kidney disease, uh, focused on individuals who have chronic kidney disease and type 2 diabetes. And just like Judge Mosley, I'm a nephrologist today because the very first day as a trainee that I walked into a dialysis unit, um, I found out that everyone looked like me. And so I was like, what is going on here? I've always been interested in type 2 diabetes because I lost a lot of loved ones to complications of diabetes. So I went into residency thinking I was going to be an endocrinologist, so focused on diabetes. And so once I started doing my training and found out that diabetes was a leading cause of kidney disease, it was I had to know more about how to prevent or treat kidney disease. Um, so the kidneys. So if you don't already know, like Judge Mosley mentioned, we all have and are born. Some people are born with one, but most of us are born with two kidneys. They are being shaped about the shape of the fist, and they're located in the back. And the kidneys have several functions. And I usually start with this because I think it's important to understand what the kidney does to be able to understand what we're trying to manage when the kidneys are becoming weak and are failing. So, one of the primary roles of the kidney is to try to get rid of excess water and waste. So, when we drink water, when we eat food, and the body breaks it down, the water has to go out from somewhere, the water that the body doesn't need. And that's why we pee urine. In addition, some waste also go out with that. And then when we eat food, when the body takes what it needs and what it doesn't need go out in form of waste, partly through the urine as well. And then the kidneys does other things. It produces hormones to help with blood cell production. It also produces hormones to help with our bone health, to keep our bone healthy. So some of those are some of those are some of the critical functions of the kidneys. So what is chronic kidney disease? So essentially, chronic kidney disease is when the kidneys are damaged and they are not able to do that basic function of the kidneys, keeping you healthy. And that's what layman definition of chronic kidney disease is. Medically, we have a way we define it, but those are high medical terms. But I think this is really what it means. When your body is not able to, when the kidneys aren't able to do its job to keep you healthy, that's what we call chronic kidney disease. Next slide, please. So, how do we diagnose kidney disease? So, This is where it really gets confusing for a lot of people that, show up in the hospital just like Judge Mosley did, because there isn't really any symptoms, and to be diagnosed, you have to have access to, health. So we need blood work, and or urine to be able to make a diagnosis. So the one thing we look at we do a blood test, and is we look at the estimated glomerular filtration rate. It's not a blood test in and of itself. It's like a calculation that we do, and we look at what we call the serum creatinine, which is everyone has it. It comes from muscle and is filtered by the kidneys. So we take that value, we take your age, and then whether you're male or female, we'll plug that into an equation, and it tells us the estimated glomerular filtration rate, which is really the percent function of your kidney. And then the other thing we look at is urine. So in the urine, we look at signs of kidney damage. And typically, the most common thing we look at is protein in the urine. We all have some amount of protein in the urine, but when the protein in the urine exceeds a certain number, then it's a sign that there's something going on with the kidneys. Because essentially, kidney, we have millions of filters. So if you think about a sink, the filter is supposed to prevent proteins and cells from getting through in the urine. Once we start seeing more than what we expect, then it's a sign that there's a damage to that kidney filter. The other thing that might be a sign of kidney damage is blood in in the urine. So if there's blood in the urine, it could be a sign. And then we'll also look at ultrasound. If you do a kidney ultrasound, and the size of the kidneys looks smaller than normal, or if there's for some reason some kind of obstruction and urine is not flowing, it could be a sign that there's something going on in the kidneys. But most times we use the urine for protein, and then the EGFR to make a diagnosis. Next slide, please. Oh, I also have history of kidney transplant. That's also a very tricky one. So, so if you get a kidney transplant, you're also considered to have chronic kidney disease, even though you might have a kidney that might be functioning. So, like Judge Mosley, he still has to go to the kidney doctor. We're watching him, so he's still considered a patient with chronic kidney disease. So I think it's also important to know what are the stages of chronic kidney disease. So in the kidney family, we use this to, look at prognosis and what are the chances of getting to kidney failure, depending on where your kidney function is. So stage one, depending on where you are, if you have kidney function more than 90%, you could still have chronic kidney disease if you have excessive protein in the urine. And then stage two, usually kidney function between 60% and about 89%. We say stage two, plus or minus excess protein in the urine. And then stage three, we have stage 3A and B, but mostly it's kidney function between 30 and about 59% is considered stage three. And then for stage four, if you have kidney function between 15% and about 29% is considered stage four. And then stage five, which is commonly referred to as end stage kidney disease, is the final stage, usually kidney function less than 15%. Next slide, please. And so, what are the causes of chronic kidney disease? The leading cause of chronic kidney disease is diabetes, 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 diabetes. And then high blood pressure. Those are the two leading causes of chronic kidney disease. Then you also have conditions what we call glomerulonephritis, is like inflammation of the kidneys, where either the body is fighting the kidneys and attacking the kidneys. We call that glomerulonephritis. And then we also have inherited genetic kidney diseases, like polycystic kidney disease, where the kidneys start to form abnormal cysts. So lots of cysts in the kidneys, fluid filled cysts in the kidneys, and it distorts the structure of the kidneys that can cause you to have chronic kidney disease. And then lupus is also another cause of chronic kidney disease. Is a systemic disease that can also attack the kidneys. Is also a situation where the body builds immune attack against the kidneys. And then obstruction is also a cause of kidney disease, a chronic obstruction, either chronic obstruction from enlarged prostate or having kidney stones, multiple kidney stones. There's situations where people who are prone medically, their kidneys are forming stones in the kidneys that can also cause chronic kidney disease. And then having repeated urinary tract infections can also cause chronic kidney disease. And next slide is who is at risk for chronic kidney disease. So definitely if you have diabetes, be it type 1 diabetes or type 2 diabetes, type 1 diabetes, most times having type 1 diabetes within 5 to 10 years of having type 1 diabetes, you know for sure you most likely will develop chronic kidney disease. Type 2 diabetes is usually tricky because most times people might be living with type 2 diabetes for a long time. So it's not, you not really know that you have type 2 diabetes, but that is also a very puts increases risk for chronic kidney disease. And having a family history of chronic kidney disease. So anyone in your family, if you have someone in your family who has who was on dialysis, who received transplant, that puts you at risk. Is always good to know why did their kidneys fail? Why did they need a transplant? Is always helpful for your own health. And also older age, as you get older, 60 years plus. So we are all born with over 1 million functioning filters in each kidney. Once we hit age 40, regardless of what you do, you lose 1% of your kidney function every year. Now, if you then layer that on, have diabetes that is not controlled, or and high blood pressure, you're losing as much as 5 to 10% kidney function every year. So that's why it's really important to know what your risks are and kind of like be very aggressive towards managing those risk factors. Heart disease is also a high risk for chronic kidney disease. And then obesity is also puts us at risk for kidney disease because your kidneys are working so hard, 2 times, 3 times, 4 times as hard as it should be, and that. And then if you look like me, if you're Hispanic, American Indian, we're higher risk for chronic kidney disease. So in the last 10, 20 years, there's a gene called ApoL1 that has been shown to put individuals who have his family or ancestry from West African origin. So there's a gene for that is supposed to be protective against African sleeping sickness. It's supposed to be protective if you're in West Africa, but it's been shown that over here, that gene mutation now increases the risk for kidney disease. But the interesting thing about that is that it's not everyone who has that high risk gene who ends up with increased risk for kidney failure. So there's still a lot of research ongoing to try to figure out what puts an individual who might have this high risk gene at increased risk for kidney failure. And then having past history of acute kidney injury, let's say for some reason you were very sick or you had surgery and you have an acute kidney injury and you have multiple acute kidney injuries, that also puts one at risk for chronic kidney disease. So what are the symptoms of chronic kidney disease? Like I said, really, no, there's really no symptoms. It's considered a silent killer. Most people who have symptoms or signs of chronic kidney disease are usually very, very advanced disease, and it can come as leg swelling, which is really not so specific for kidney disease because leg swelling can be a sign of so many things. It could be a sign of venous insufficiency, it can be a sign of liver disease, heart disease, so really not specific. Fatigue, again, can be very non-specific. I get tired a lot when chasing the kids, so it really doesn't, tell me much. So it's really non-specific, so not very helpful. Difficulty sleeping, dry, itchy skin are some of the symptoms. Shortness of breath, which is also not specific. Lung disease can cause shortness of breath. Heart disease can cause shortness of breath. But from a kidney standpoint, if your kidneys are getting weak and you're not able to get rid of all that water, that can cause you to be short of breath. Increase or decrease urination can also be a sign, but again, really non-specific. Um, so how do we manage chronic kidney disease? So unlike diabetes or high blood pressure, where we have like medicines, okay, to take for chronic kidney disease, management of chronic kidney disease is really geared towards managing the risk factors for chronic kidney disease. So, blood sugar control, blood pressure control, those are really critical, especially early on. Diagnosis of chronic blood pressure or diabetes. Being very, very serious about controlling those risk factors is what is really key to managing chronic kidney disease. And the big one also is lifestyle changes, which is the hardest part, trying to eat healthy, and then trying to engage in physical activity, having a routine. If smoking is a problem, trying to stop smoking, and then taking medications as prescribed for, all medical problems. And then also being very cautious about medications that you get off the counter, making sure you run them by your doctor before you take those medication. Next slide. So kidney failure management. So once the kidneys fail, essentially when the kidneys are functioning at less than 15%, there are three treatment options. And really, these management options really technically start when the kidneys are less than 20%. We have dialysis, um, kidney transplant, or supportive management. So once the kidney function is less than 20%, we start having serious conversations about what is the plan? How is the kidney, how are we going to manage the kidneys if we get to that point? Next slide, please. So the first thing I have here is kidney transplant because that's the ideal, but it's also the hardest, as you heard Judge Mosley talk about. So kidney transplant is essentially getting a new kidney to take on the role of your kidneys because your kidneys aren't able to do that. So typically, you need to be referred to a kidney transplant center for that, and it's a long process trying to find out if you're a good fit to get a kidney, and also if it's a living donor. Like Judge Mosley got a living donor transplant. Sometimes it might be a deceased donor transplant, so that means the kidney is coming from someone who has passed away from other medical problems, but they still have a good kidney that somebody else could benefit from using. So the wait time for the kidney transplant it goes from months to years. It depends, but that conversation starts once the kidney function is 20% or less. And then the second option is dialysis. So there is hemodialysis, which essentially means that the kidneys are weak, they can't do their function. So we have to have a way of cleaning out the blood of waste and water. So the blood is taken out from the body. It goes through a machine, which serves as artificial kidney. It cleans, takes out waste, takes out excess water, and then puts it back. So the process for that is also different because we need a wave to get the blood out of an individual with kidney disease. So it's either through a line or a fistula, like Judge Mosley had. So there are two ways: is either in center, so you go to a center where there is dialysis and there are chairs, or it can be home hemo, which is you're getting dialysis, but it's happening in your home. As you would imagine, this is very difficult to have. Is a lot of information in 30 minutes, so it's kind of like just I'm not going. Yeah. And then the other option for dialysis is peritoneal dialysis, which Judge Mosley already also touched on. That form of dialysis, you also need an access, but a different kind of access. And the goal is to get sugar water into the belly. There's a sac in all of our bellies called the peritoneum. So we get the water into the belly and it sits there for a while. And in by the walls of that sac, we have different little blood vessels. So the exchange of the waste, because there's high waste in the blood, if the kidneys are not working, it goes exchange back and forth with that water, and then it sits there for a while, and then after a few hours we take out that water, we put a new one. So that's really what goes on for those number of hours that you're getting the peritoneal dialysis. Typically ideal for individuals who are still working or students who are like up and about, and it can be done at night. Anyone really can do any of them. It's really about a conversation between your provider and yourself, and we'll see, okay, what is the best for that. And then the last option is supportive, and really that's in some cases, some individuals start dialysis and for some reason they don't think is working for them anymore. They don't want to continue, or at some from the get-go, once the kidney fails, they don't want to do dialysis. Then is a conversation about how can we just support your health until the time comes. So we're just managing blood pressure, we're managing anemia, all the things that the kidney does as best as we can, without offering any of those management options. The next slide. Okay, and so just a few. Okay, okay. So I have a couple of programs ongoing for individuals with chronic kidney disease and diabetes here. And the first one is it's really about, and the premise of this study started from once I moved here in Milwaukee and started having community focus groups and talking to individuals with chronic kidney disease. And I realized that there are so many things, so many things that go on in our lives that make us prioritize other our health, other things above our health. And that was where this study came from. And so the goal of this study is to see if for individuals who have uncontrolled diabetes with chronic kidney disease, who are dealing with other life issues, financial issues, food, transportation, if providing education for chronic kidney disease and diabetes, and also helping them navigate those social issues, and also teaching them how to manage their kidney disease, the impact, how that would impact the outcome. So that's really the goal of this. So, and usually it's a 6 months study, and you'll be on the phone with a health educator. She walks you through chronic kidney disease, diabetes, teaching that for a period of about 12 weeks, and then take some blood and see how that impacts outcomes. So that's really what this study is all about, but it's focusing on, it's just for African Americans with type 2 diabetes and chronic kidney disease. And then, and so I think that's the same study. And then we'll be checking A1C and that. And then for this other study, is also recognizing that you don't know what you don't know. So we're talking to patients with chronic kidney disease and diabetes, and we're also talking to providers. We're talking to their caregivers to learn about what makes managing chronic kidney disease and diabetes challenging, and just learn from them and see what program we can develop to help individuals who might have other life issues and plus diabetes, uncontrolled diabetes and chronic kidney disease, how we can learn from them and then create a program that will be best suited for this population. And I think that is the last slide. If you have, thank you.
I don't know about you, but thank you, Dr. Ozia. That was really, really great. I'm sure that's going to and I'm sure that's going to generate a lot of questions. So again, I'm going to remind you that after our next speaker, not to put any pressure on him, but after our next speaker, we'll then have a session where we'll do some question and answering. And so I look very much forward to that. Our next speaker is Dr. Lawrence Sanders. Dr. Sanders received his MD degree from Vanderbilt University College of Medicine and then completed a residency in internal medicine at Emory University College of Medicine. He subsequently earned a Master's of Business Administration from the Wharton School at the University of Pennsylvania. He is a past president of the Atlanta Medical and the Georgia State Medical Associations, and he's also past president of the National Medical Association, which for those of you who may or may not know, that's the largest organization of African American physicians and the oldest one in the country. Dr. Sanders is currently the physician advisor for clinical documentation, improvement, care management, and hospital throughput for Grady Health Systems. And he's also the chief medical officer for the HEAL Collaborative. Dr. Sanders will tell us a little bit about diversity and policy in renal disease. Dr. Sanders.
Thank you, sir. All right, good morning, everybody. All right, you've heard a lot over the last 2 days. You've heard a lot about treatments. You've heard a lot about kidney disease. And you've heard a lot about the advances that we've made in the treatment of kidney disease. And I think you just recently heard from the physician who was just before me about some of the studies that she's engaged in and about some of the research that she's doing, and the value of that research in improving how people with kidney disease can better interact with the health system, and also how by talking to each other, we can learn how better to treat people with kidney disease and have better outcomes by talking to patients and physicians and understanding the challenges. And that's research. So what I'd like to spend the next few minutes doing is talking about research and the value of research and trying to get over this myth that I don't want nobody doing no research on me. All right? So with that as a backdrop, what I want to do is talk about clinical research. And clinical research involves people. My objective is at the end of this is to create a framework that more of us understand clinical research and may be willing to participate. And I want to take 5 steps to do that. I want to talk about clinical research and kind of define it so we know what we're talking about. I want to talk about the benefits of clinical research. What have we learned through clinical research and how has it in fact impacted how we care for people? And then I want to talk about who participates in clinical research. And then I want to really deal with the topic of us as African Americans participating in clinical research, why we don't do it, and what we need to do to make sure that we will do it. And then finally, kind of sum all that up as to why this is important to each and every one of us. All right, so research. I don't really have to do a lot to explain research because I think the physician before me really talked about research and at the end there and kind of the research she's doing. Research is not limited to people doing experiments on you, doing things that are not good for you. It's really about having an idea, learning how to improve it, such that it gets better and better. And when we apply that to clinical research, it involves people. There are two kinds of clinical research. There are clinical trials and there are observational studies. Observational studies look at the progression of a disease over time just to better understand it. And clinical trials or clinical research may look at new drugs, new ideas, new concepts. And I think one of the things you heard yesterday, I want to pick up from yesterday a little bit from Dr. Williams. She talked about the diabetes trials or the diabetes trials for clinical kidney disease and what the impact of a healthy diet is on those outcomes. And I think you heard that across the board today, how important. We know that because of clinical research and clinical trials. Most often, clinical trials evaluate new procedures, new treatments, new surgeries, new prevention, new ideas that lead to improvements. Not so much, they benefit the people who participate, but the real people who benefit are our grandchildren and their children. So it's forward thinking. So now let's talk about clinical trials. There are basically 4 steps to clinical trials. Clinical trials can involve drugs. That's what we're going to talk about mainly, is how clinical trials impact new treatments and new drugs. So let's start with clinical trials. I really want to talk about what are clinical trials and what are the 4 phases. All right. So the first phase of a clinical trial, let's say I have a new idea for a new medication or a new treatment or a new prevention strategy. The first thing I want to do is make sure it's safe, that it doesn't hurt anybody, that it's safe. So I do that by taking healthy people and engaging them in the trial to determine what the side effects are, how much medicine or what the dose should be, and to make sure it's safe. Once I understand that it's safe, I move on to the next step, and that's phase 2. Phase 2 then looks at people with a certain condition to find out if it works. Is the new treatment effective? Does it work? So step 1, let's make sure it's safe. Step 2, let's make sure it works. Step 1, we engage anywhere from, I'm going to say, 20 to 100 people in that study to make sure that the medicine is safe. Step 2, we do the same thing, another 20 to 100 people to make sure that people are getting what they need. And then finally, our third step in that is we want to compare it to the medicines that we already have. So if we have a new medicine or have a standard treatment, we want to compare what's new to what we already have to see if it works better. And it also continues to look at safety and that it works. So you've heard me talk about safety in every step of this process, such that clinical trials really try to make sure that everything is safe. All right. So now phase 3 also looks at how that new treatment or that new medication interacts with people of different groups. Not necessarily always based on genetics, but we share a lot more things than our genes. And I often ask people, who taught you how food tastes good? Who taught you? Your mother or your father. And so we share that pattern. And so if they tasted it, put a little bit more salt on it, tasted it again, put a little bit more salt on it, taste it again, such that you grow up learning what good food tastes like. So we share a lot more things than genes, where we live, the exposures that we've got. All of those things are worked out in phase 3 of clinical trials. Now, in order to get a new drug or a new treatment to market, it has to be approved. And for drugs, they're approved by the FDA, the Federal Drug Administration. Once that drug is approved, it's now on the market. Clinical trials continue. And we monitor again the safety and effectiveness. Now, so that's clinical trials. Seems like there shouldn't be much of a problem. And if you think about it, we've talked about diabetes and we've talked about chronic kidney disease. Over the last 100 years, the number of new drugs and new treatments really just exploded and really improved our, our lifestyle and how long we live. All right. If we go back to the 1900s, the average life expectancy for people was around 50 years. All right. And it wasn't until we came along and began to control infectious diseases that we began to see people live longer. Now, there are a couple other things that go into that. We got clean water, we got hygiene, we were able to live in tight environments, but mainly we were able to control infectious disease, and that was because of antibiotics. And so the first antibiotics came out of research, and now we have so many more. And I'll use even diabetes, and I'll use what you see on TV almost every night, the Jardiance dance. That's a new medicine. And I know everybody's seen it. It's a new medicine that treats diabetes and has better outcomes, and that came through research as well. So if we find all these benefits, why don't people want to participate? If we look at participation in clinical trials, and we look at people who look like you and me, we only make up about 5% of the people who participate in clinical trials. For the longest time, the people who participated in clinical trials were white men. But we need everybody participating in clinical trials such that we learn how these treatments work for us. Am I making sense? Okay, so we have to learn how these treatments work for us. So if this is all good, why don't people want to participate? It goes back to what I said in the beginning. Nobody wants me, nobody wants research done on me. All right, now, if I try to capsulize that and talk about what is it that people are concerned about, most of us will go to something called the Tuskegee Syphilis Study, or the US Public Health Study of Syphilis that went on from 1934 to 1965. All right? Now, that study enrolled, I don't know that I'd say enroll, but it engaged men who had syphilis without them knowing. And it was a study to look at the course of syphilis. It was an observational study, right? And so as a result of that, people distrust the system. And I'm going to be clear. Given our experience, distrust of the system comes naturally. I mean, I'm just going to say it. I don't know any other way to say it. So what we have to do now is look at the safeguards and the things that have been put in place that protect us, but that protect everybody who participates in a clinical trial. Remember I said the US Public Health Service study on syphilis enrolled people, and then I stepped back and said maybe they didn't enroll people. They got people engaged. Because today, if you engage in a clinical trial, you have to sign a consent. And in that consent, it should lay out the benefits of that study, the downsides of that study, what's expected of you, and what's expected of the researcher. And that clinical trial has to be approved by what we call an institutional review board. At every institution that's doing studies, that group is made up of other researchers and people like you who want to get engaged. And I would encourage you, if you're interested, if somebody asks you to participate in an institutional review board, it may not be a bad thing to do, because what it does, it brings a broader perspective to the researchers. So with that, we can do better, because now nobody's going to enroll you in a trial without you knowing it. People are not going to do things to you without telling you. And it's focused on safety, because the outcomes of clinical trials really frame all of the new treatments, and what may have been experimental or novel at one time then becomes the standard of care. And that's how we make advances. Now, For the last 20 years, we've been talking about trying to get more people who look like you and me to enroll in clinical trials. It may even go back for the last 30 years. Well, still, we haven't done it yet. Even to this day, the federal government and the FDA has really put in place guidelines that every clinical trial has to have diversity. And diversity means people from different races, different genders, different environments, different places where they live. Right? And so with that comes the safety. But we really can't, in 20 years, erase the experience of 400 years of systematic oppression and mistrust. So you have to go into the clinical trial with your eyes wide open. Okay, and you have to go in, and if you need somebody to go with you, you should. Now, how do you find a clinical trial? Because in spite of all the things I've told you about why not to participate, the outcomes and the benefits to you as an individual, but because sometimes based on the condition that people have, a clinical trial may be the only access to new medicines and treatment. And the other thing about clinical trials is that you clearly see the benefits. We have clearly seen the benefits. Other thing I would say, if you want to participate in a clinical trial based on the condition that you have, the government has a website. I guess it still works after yesterday. It has a website called clinicaltrials.gov that lists every clinical trial, that lists all of their requirements for participation and the safety issues. Can you hear me? Okay. All right. All right. So now let's kind of get on to the end of this. What I'm going to say is this, that even in the face of clinical trials, there's some things that we can do better. First of all, I'm very happy to see that the physician who spoke before me is engaged in clinical trials and engaged in clinical research. Because the majority of people who are doing the research don't look like you and me. So the first thing we've got to do is really increase that pipeline such that there are more researchers who look like you and me. Because one of the things I learned in medical school is the best way to care for a patient is to care about that patient, and some of it comes from shared experiences. So we need more diversity in the researchers. Now, the second thing is, so often you have to go somewhere for the clinical trial, and that's difficult. So one of the things we may need to do is figure out how to bring the clinical trials to the neighborhoods and communities where people live. And we need to improve our communication about clinical trials such that people really understand the benefits. I'm going to leave one thought with you. Why participate? Benefit to you. But really, if you've listened carefully, the benefits go for the generations of people who come after us. And that is what is most important. That is what's most important, because it's about all of us working together to create the best conditions in every neighborhood to give every individual the best opportunity for a healthy life. Thank you very much, and I'll be glad to answer any questions that you have.
Dr. Ozia, why don't you come on up, please? Ozia, come on up. I want you to sit down. We're going to take a few questions and try to address some of the various issues which have been already discussed. Just go ahead and sit up there. I promise you, Dr. Sanders does bite, so just stand to the side. But before we do, I just want to ask one question. Why did you come here today?
My pastor made me. Um, our pastor really pushed this summit that we came to yesterday and today. And also I currently have chronic kidney disease. And talking to a lot of doctors, sometimes you think that they just kind of push you out the office. And I wanted to come here and try to get a little bit more knowledge, see if there's some things that I have not heard yet that can possibly come in.
Well, thank you very much. And I guess your pastor's a pretty good dude, huh? Dresses well, too. I understand that. Thank you. So let's talk about that point. How, tell me a little bit about the interplay between the patient and the physician when we're talking about a problem like renal disease. Because as you said, Dr. Ozia, there was nothing that's specific about any symptom for kidney disease that tells you, hey, you've got kidney disease. I think you have to look at what the whole constellation of symptoms. So often we'll dismiss, like you said, oh, you're just tired because you're working hard. Describe for me what goes on in your mind when that patient comes in with symptoms.
Yeah, so I think the patient provider relationship is very critical. And I think opportunities like this to listen, to learn, I always focus on it's very important for me as an individual to understand what kidney disease is all about because I'm going to be my primary advocate. I come into we all go to see the doctor if possible once a year, twice a year, depending on what medical problems we have going on. So the physician can only do so much in 30 minutes or 20 minutes. So the more I know as a patient, the more I'm able to do for myself. And, and I think you talked about this. I always emphasize on it's very important that I find a provider that I trust, that has my back, so that I don't go in and they make recommendations and then I step out, I decide not to, you know, go with those recommendations and then end up hurting myself. So it's important that I do my research. I do that even as a physician, I do my research before I choose my own doctor. So do your research and go to a doctor that you trust, that they have your back and they care about you. And when they make recommendations, take it. Do as they recommend because if they have your back, then they're trying to help prov- prevent either disease from getting worse or you ending up with complications of that disease. So that's what I would
All right,
say.
now you talked about genetics, and I
Yes.
want you two to get back that minute. Which one is more important, or is it an interplay between the two? My genetic code or my zip code when we're talking about renal disease?
Well, that's what research is really
No,
going
no, you're
into
gonna get
right
off of that.
now.
Which one
No,
is more
I'm
important?
not
No,
getting
don't
in.
tell me that.
I can it is an interplay.
Uh-huh.
Yes, it's a very strong interplay, which is why now we talk a lot about social risk because zip code is social risk, right? So and that's why we're trying to figure out what, if any, is one more important than the other, which I don't think. I think there's a strong interplay because, like for I said, like the APOL1, not everyone who has that gene risk ends up in dialysis. We found out that people who have, for example, HIV, they are sevenfold at increased risk if they have that high risk of progressing to kidney failure. So there's still so many other things we don't know that might put an individual at risk, which where brings in the clinical trials and trying to learn about what are these factors and how can we mitigate them.
Right. I'd add to that just that I think it's an interplay. And I think if you heard Judge Mosley, he clearly said that his mother had a kidney transplant and his father had kidney disease. And subsequently, he developed kidney disease. So it's really an interplay. But the most important, as important in your health is not only your genetics, but I really believe that your zip code really plays an important point. And all of us have to work together. And it's really about the people who live in that zip code connecting together to improve the conditions and make sure everybody has the best opportunity for a healthy life.
I want fair warning to the folks in our policy portion. I'm going to ask that same question, but in a different way. And I want a better answer about how we get engaged so we look at those adverse factors that are impacting people in health. If anyone has a question, please raise your hand and I'll come down to you. What are we thinking about? I'm sorry. I was standing right there. You just gave me the eye. I didn't know which eye you were giving me. I thought you would give me the side eye. Okay.
Hi. My question is regarding the gene that you mentioned, the APL. Um, I would like you to explain that a little bit more. My family is researching their ancestry, and I found out that ours comes from the Burkina Faso, and I think that's Western Africa. My brother does have CKD. I'm learning that term with you all. Um, he does live in 53206 zip code. I don't know of anyone else in my family with CKD, but that goes, I don't know. They got to pass before, it was found out or diagnosed. Like you said, some people, men mostly don't go to the doctors. So just explain that gene more for me, please.
Thank you. Thank you very much.
Yeah, so there's still a lot that isn't known. It's not something that is routinely screened for. Right now, I think, and then the NKF, I think they have a talk on transplant next month. But I think primarily people who routinely get screened for the APOL1 gene are people who are either in the process of donating a kidney or getting a kidney, I think is one of the routines they do now. But in practice, it's not a gene that we would routinely screen for. That said, the lab, I think is Arcana Lab, I think they offer like a free screening for individuals who would like to be screened for the APOL1. It's APOL1 gene who would like to be screened. But like I said, there's still a lot that isn't known. Even having a high risk gene doesn't mean that you're going to end up with kidney failure. There are people who have the high risk gene who are fine. There are people who have that high risk gene who end up needing like kidney replacement therapy. So there's still a lot of ongoing research. I know that there's a current study, clinical trial going on right now for a medication that has been developed targeting individuals who have the high risk gene to see if that medication, I don't know what phase of clinical trial, it could be phase 2 right now, trying to find out the safety of that medication and the impact on and the effect of the medication for those who have that high risk gene. I know there are studies ongoing right now, and I think there's actually one ongoing at Fredert.
Dr.
For
Sanders, before
yes.
we go into a question, I want you to tell me something. What does the black person look like? And how do we make that definition of a black genetics code? I mean, you come from South Carolina. If I'm not mistaken, there was a lot of people taking trips down Slave Row. And we got a whole hue of people. So exactly how do you define someone as being black?
It's based on what they look like. It is not based
Are we
on
talking
any-
Sally Hemings black or are we talking Miles Davis black?
It could be all of the above.
Okay.
And if you look at how historically it was done, and I'll speak to South Carolina, it was any drop of blood that was not white made you black. But what I would say is that in contemporary American society, race is determined by the way people look and by the way society assigns that race on the way people look. It is not a genetic framework, because if you look at the genome, all of us as humans share more in common than we do differently.
Okay.
It's the same. We're all human beings. But what begins to bring out the differences is where we live, what we're exposed to, what we eat, what goes on in an environment. Those are the things that create the differences. Now, there are certain things that are passed genetically. There's certain things that are passed genetically. And I think that's important. I never want to downplay that. But I also want to make sure that we don't let ourselves off the hook, because many things that we share may look like genes because we learn about them in our families, our diet, our habits, our exercise, all of those things we learn, and those are things that we can change. And so that's why I always want to say, I don't want to let us off the hook, because we can do better even with our genetic profiles.
Thank you very much. We have a question back here.
Good morning. Actually, I have two questions. My first question is, you talked about the 5 stages of kidney disease. Is it possible, like if you were in stage 3, if you use those protective factors that you were talking about, can they be reversed?
That's a very good question. Yeah, so chronic kidney disease is irreversible. So we think about it as a scar of the kidney. So the whole goal is to prevent progression of kidney disease. So if you have a scar, I have one that I've had here since elementary school, it doesn't really go away. So the whole goal of management is to try to prevent it from progressing. So keep it where it is until the rest of the life that you have to live. Does that answer your question?
Yes, thank
Okay.
you. My next question is, can environmental trauma be a factor in kidney disease?
I promise you, I did not put her up to that question.
Yeah. Can you expound on what you mean by environmental trauma?
Yes. So what I'm talking about, when you have a lot of those risk factors, maybe you're a child or individual that's growing up in a home where maybe it's lead in the house, or maybe they're living in that, like they explained to us last night, like a swamp desert, or they're not getting the health care. So like the things that's like in their environment.
Let me add to that though. So one reason why we asked a question about zip code versus genetic code. So if you're looking at air pollutants, parts per million, 2.5 microns, and their impact on vascular function, which gets into the kidney. Not only what you talked about for this, medications and that. So all these are the environmental factors. You talk about weathering. I don't know if everyone's familiar about the concept of weathering, all these adverse events that impact upon us, causing adverse inflammatory changes, which can give rise to things like kidney disease. I think that's what you're kind of talking about.
Yes. The short answer is yes. Did you want to say
Yeah, I'm
something?
going to say something. You know, I would also say something else, that there have been a number of studies that have just shown that, quote, the stress of being an African American, end quote, increases your risk for high blood pressure. Because stress triggers hormones that then impact the way your body handles fluid, the way your body handles salt, the way your body handles sugar. And sometimes, some of us in stressful situations just look to the sugar, if that makes any sense, or look to food as a stress reliever that then leads to other problems. So yes, I think the point I'm trying to make is that all of these things interact together, and I can't separate out what impacts one disease versus another disease, because I think you've already heard that diabetes, hypertension really are the leading causes of chronic kidney disease. And those are really fundamental to that we can impact by what we eat, what our habits are, and how we live and share things together.
So I think the two things that you two are both saying is that there are these external factors that give rise to stress. And this what gets into this concept of weathering, increasing catecholamines, et cetera, giving rise to diabetes, hypertension, which gives rise to the renal disease. All right, your question, please, ma'am.
Her.
Not you. Oh. I ain't got so many bend downs left in my life.
Hi. So my question is specifically about clinical trials, and it's kind of a two-part question. So my first question is, does a participant in a clinical trial are they guaranteed to be a recipient of that new drug that's being researched? Because most of my understanding about clinical trials comes from like television, Grey's Anatomy, stuff like that.
Yeah.
So, and then like the next part is based on that. So like, if they aren't, are they that person expect to like kind of forego treatment during that trial simply because they're not a recipient of it.
All right. I'm gonna kind of take your question and pull it apart a little bit and pick up some of what I know from TV as well. Are you in the trial, or are you getting what's called a placebo, which is nothing? Is that the question? All right. In today's world, most clinical trials, because we have made so many advances, are comparing the treatment we have today, which is the best treatment we know at the present time, to the new treatment. So most of the time, you are getting a sufficient treatment based on the best knowledge we have today to compare it to the advance. So very rarely in a clinical trial today are you going to be in a placebo arm of the trial. Did I answer your question?
So are you getting standard medication or some kind of medication?
You're getting the standard of treatment compared to the new treatment.
And at the end of the trial, if a person was getting the old medication and it looks like the new stuff is working, would they automatically be able to receive the new medication?
It depends. It depends on the trial.
Okay.
Yeah, I think it really depends on the trial until that new medication is approved.
Okay.
But it's not like you're not getting any treatment. You're getting the best that we have today, and so that's one. That's just the basics of clinical trials and research and the structure.
All right. Did you want to comment, Dr. Osea?
Yes, I would also comment that most times this is also explained. That's the informed consent process. So trying to understand that, because sometimes, like they have two arms of clinical trial, depending where you get the placebo or you're getting the active treatment, there's no way, if they do the randomization, which they usually do, there might be no way to guarantee which arm you are put in. So those are things you can clarify at the point of getting into, if you're interested in getting into a clinical trial, and they can they can clarify that with you. Sometimes some of the trials, they do what they call a wait list. So they might randomize you to placebo where you're not getting the active medication that they're trying to figure out if it's effective. And they randomize you to an active treatment. After the certain period, they switch everyone and you still get the active treatment and another group. But it depends on the design of the study. So those are things that can be clarified because every clinical trial is different.
Dr. Sands, you had one other comment.
Yeah, and it's not out of the question if one arm of the trial is showing significant improvements or the other arm that the trial will be discontinued and everybody will be switched to the new arm. So I think that's another important thing to remember. But I do want to go back to one thing, and we've talked about it. I sort of alluded to it. If you choose to participate in a clinical trial, there are a couple of things that you need to know. You need to know as much about your disease as you can, the stage of your disease, and any other details that you know that you can learn about your disease. So that means you've got to educate yourself. You also need then to understand that consent and the informed consent process, because it should explain every aspect of the trial, what you should expect. And I always tell people, don't go into a clinical trial yourself. Have someone that you trust with you who's going to help you answer your questions and maybe see some things that you may not see otherwise. And just to take that back to the basics, sometimes it's a good idea to have somebody go to the physician with you, to go to the doctor with you, because if they're telling you something, you may not be listening, but that other person is listening. I'm going to say women do a better job at that. Almost all men need somebody to go to the doctor with them, no matter who they are and what they do.
Yeah, you're pandering to the audience. But this is going to be our last question. And for the both of you, I don't care what he asked, the answer is yes. This is a big brother. So yes is the answer. Go ahead.
My question is about education and advocacy. How do we get communities to take interest in learning education so that we can advocate for ourselves and others? The reason I ask that because when my father was ill, there was so much information I had to go and research. So when doctors were trying to prescribe certain things, I was able to make sound decisions. But what I'm seeing is that there's not a lot of people caring enough to get the information to be their best advocate. How do we interest individuals and communities to want that information?
And before you answer it, you also, thank you very much. That's a great question. But before you answer it, you've got to tell me, how does Dr. Google compare with your 4 years of medical school? And how do you know what's good information and what's bad information?
All right. Oh, that's a tough question. Yes, sir. The answer is yes. All right. I do what I'm told. All right. But I do want to go back to what you said, and I think an important part is doing what we're doing today. And I think the church is a good place to do that because this is a place where we have come to understand each other and that we're acting in our best interest. And one of the things I try to do here is to be a little bit provocative such that you'll go tell somebody, you know what that doctor said? Such that you pass it on one to one because that may be the best window into helping somebody else get to the next level. And I'll share just that story because as I listened to Judge Mosley, it was because someone went into the restroom after him and noticed something and said something to him that he went to the doctor. So you see how much, I mean, this is good. But the best way to get information, or the information, or get the handle, is to talk to somebody you know and then go do your research. Now, Dr. Google. There are a couple of trusted websites. Some of the websites that I would say you have to go that are trusted should be medical websites. Mayo Clinic, I'm sure the medical center here has a website with information. I'm old enough to remember the first time a patient came into my office with a printout from the computer, and it was on that green and white paper with the holes down the side. Most of you may not remember that, but the first thing I said was, "What is this?" And I tried to put it down. But what I have learned is now what I do is I go through that information with them, try to discern using my best understanding if it's accurate and reliable. And if not, I redirect them to another website. So I think working with your physician, working with others to find good information, because you can find anything you want on the internet to substantiate whatever you want. So you've got to get good information. And the more information you have, the better equipped you are.
Yeah, I think that was a very good question. I think, like, for example, the National Kidney Foundation, but again, the question is you have to know that there are such organizations that exist. For me, for my practice, that is a website and a resource that I give to all my patients, all of them. I tell them about the National Kidney Foundation website. There are a lot of patient level education broken down in a way you can understand. And if you don't understand, I always is like a homework for my patients. You take that website, go read, and I want you to come back with questions. Because I find that there is only so much education that I can give in 20 minutes or 30 minutes. And then, like you said, sometimes you're just not there. You're just so stressed out that you've been told that you have kidney disease that half of what is said, all of what is said, doesn't even get in. And then you leave and you don't like what just happened. So having that written down, National Kidney Foundation, they can go back, go look. You also have the National Institutes of Health, NIDDK. There's an institute specific for digestive disease and kidney disease. They have a lot of information broken down in a way that, everyone, patients with kidney disease can understand that. Well, at least start basics, read, and then you can come back and discuss with your provider. So I think we can start from that. Yeah.
Well, thank Thank you very much. And how about a hand for yourselves? The questions. Just for now. Dr. Hosea, you can stay up here if you want to, or you can sit back down. It's up to you. See. Now, you want to join these people over here? Now, these are not physicians on this side. You know, you got to watch yourself, man, because, you know, these are not doctors. They don't speak the same language. Well, I know you make this not true. You said it's true. Very good. Let's shift gears a little bit. Let's kind of get into a little bit about policy things. And so we have on our panel, you already know Dr. Saunders. We have also, of course, Superintendent Walter Fields, who's a senior pastor here at St. Paul Church of God in Christ, who, as we all know, has a tremendous influence of those who's here in the congregation, but also, as we noted, again, a very natty, as they used to say, natty dresser. He's also an author, philanthropist, and speaker. We have the Honorable Howard Mosley. Mr. Mosley is a retired, I know, Mobley, I know, because he was getting on justice earlier. He was getting on, I just want to see if he was paying attention to what I was saying about him. But Mr. Mobley, he is a retired Georgia State Representative, and he's also the corporate treasurer for the HEAL Collaborative. Mr. Dan Pavicic, come on down, Dan. He is a triathlete in his spare time is the senior vice president for sales with Ardelic. And then also we have perhaps the most important person of all. Let me get you up here, Dr. Ms. Drake. All right. And like I said before, the most important person going up there, and I somehow have lost all. Oh, here we are. I just want to make sure I get you right. Is Representative Dora Drake. Representative Drake is a native Milwaukeean, grew up in the Graceland neighborhood. She's a graduate of Marquette University, where she received her bachelor's in social welfare and justice. Currently, she's in the middle of a job change, from what I understand. You know, some people just can't keep a job. It's a shame. But anyway, right now she's 11th, she represents the 11th district, but I believe come July 30th, she is the state senator representing the 4th Senate district. Now, please, no one take this the wrong way. There was supposed to be another person on this panel, but she beat her, and I don't think she wanted to show up. But anyway, I'm just saying, no, I'm just teasing. I'm just teasing. And this is our panel. So let me start things off, and I'll give this microphone to you in a minute. Why are we here talking about a clinical disease? Why are we going to talk about policy and policymakers? How can we affect this, and what difference is that going to really make? Give us the roadmap and how this happens. Let's start off with you. Yeah, since you took it, Representative.
I want to make it fun.
No, let's go ahead. Start with you and then pass it down that way.
Why are we here today? I can tell you why we are here today. And it really is to do exactly what we've been talking about, and that is bringing information to the community. This place right here, as Dr. Sanders said, is the place where you get to ask the questions that you can't get answered in anywhere else. You get to ask them in a place where it's safe, because your pastor would not let anybody in here that's going to harm you. And so, say it. So we're here to bring this information to you, and a lot of it, as you heard yesterday, those of you here yesterday, can be very technical, and you sit here and you listen to it, and you're like, okay, do I understand what I just heard? And then you come back today and you hear a very down to earth, and you hear all the different pieces of that, and so you get the whole entire picture of what this particular disease is about. And then you get us coming up here talking about how do you actually advocate for a change in your community. So you can have actually access to more healthcare, or you can try to stop things that are preventing you from having access to healthcare. The only people in the United States that affect public policy are elected officials. And you have to come down this pathway in order to see change. And that's why we are here.
Senator Drake, take us through this. So you're here. I'm gonna say Senator, right?
All right.
I'm not jumping the gun now. I don't want to put no bad vibe out there for you. So, Senator, tell us, what difference does it make, these people here, in terms of what happens
It
at the
makes
state capitol?
it makes all the difference. And so at the state capitol,
there are, I can say, at least 50, 60 bills introduced today, that are sent for co-sponsorship. And these range from all different topics, right? And a lot of these bills are either policy changes, some of them have funding attached to it, especially when we go through the budget process every 2 years. And some of them are harmful based on who has power in the legislator. At the state level and federal level, it is partisan. And so, though I think that can push people away, it's necessary to get in that. And I can explain a little bit why. Wisconsin has not yet expanded Medicare, Medicaid for healthcare. So when you talk about access to quality healthcare, those are one of the reasons why we don't have it yet. And it's based on who's elected and who also has the majority, Democrat versus Republican. And because we haven't passed that due to the Republicans saying we don't want to expand that. And that is something that we believe that you should be investing in that. But I think it's going to be easier for me to share an acronym. And if you remember SEAL, you can seal the deal. So SEAL stands for strategy, elected officials, your antagonists, and lobby. Does everyone here know who their state electeds are? By a show of hands.
Wow.
That is the first step. You should know who your state representative is, who your state senator is, and even who your alderperson and your county supervisor, because each level of government has different things that they can address. At the state, I can't fix your roads. That's a city issue. However, I can ask the state to put more funding towards our city government so you have the funding for the city roads, right? And so it's important to know who your elected officials are, but then to take a step further, this is where strategy comes in. You should know who the chairperson is of all the different committees that you're striving for. So if we're trying to introduce a bill, say to invest more clinical trials specifically for kidney disease. You should know who the chair of the health committee in the assembly side and the Senate, because there's two separate houses. You should also know who the power players are in the finance committee, because that's where all the money goes to and gets approved of. So you need to know who those folks are, right? And then this is where lobbying comes in. And lobbying is nothing more than you being an activist that's having a conversation and relationships with your elected officials and state departments. That's all that is. And I can tell you that relationships matter in what we do, because you can have someone that you think, oh, they're going to champion this bill. Great. But the rest of the building may not like that person. And that is a hard reality when it comes to politics. And so, and then you have to realize who your antagonists are, right? Who are the people or groups that you think are going to kill the bill, that will try stall it, or say, I don't know, maybe I need something in return, right? That's where you need to know the relationships. That's also where you need to figure out, is there a way that we can compromise to still move the needle forward? And so if you remember SEAL, strategy, the elected officials, antagonists, and lobby, then those are the key components that you guys need for all of us to successfully succeed. And I can tell you, I'm always open and I want to learn more about what's happening, because we don't know everything. And any elected official that tells you they do are lying. They're simply lying. We are here to serve you, and that state building is your house. So the more that we see of you, that warms my heart, because I'd rather see people from my community and my district than other players.
All right, Dan, you just heard the setup that we heard. So you have a product that is going to help folks who have hyperphosphatemia, elevate levels of phosphate, in terms of improving the overall quality of health of these individuals. So tell me, how does what your company does in trying to help folks with renal disease interact at the legislative level?
Happy to answer this. And with all due respect, I was introduced as Dan Pavicic, a senior VP at Ardelyx and as a triathlete. But let's just ignore all that. And let me just tell you, while I might not look like many of you in this room, I'm from a place just like this room, born and raised in a zip code and a setting just like this in Gary, Indiana. And I care about you. I see you, I hear you, I love you. And in my role at Ardelyx and the work that we do for people of color who are disproportionately affected, unfortunately, by kidney disease. The work that I put in and the hours that I and my colleagues put in, I hope will benefit you, your community, and all of your loved ones. My brother is about to go on dialysis. I'm his legal guardian. My father died on dialysis. The work that I do also, it's personal, that I'm going to help my brother. And through the work that Ardelyx does, not only with developing innovative first-in-class medicines, but also through the policy work that we do, we will help people like you and your community and my brother, okay? So what we're trying to do with this piece of legislation that has tremendous bipartisan support on Capitol Hill with our elected officials. There's a bill, it's House of Representatives Bill 5074, will be a policy that allows physicians to continue to make individual healthcare decisions for their individual patients and not allow corporations like dialysis organizations to make those decisions for. So by reaching out to your elected government officials at the local, state, and federal level, you can help influence policy. And this is just one example of a healthcare policy that affects minority healthcare and diversity, equity, and inclusion in healthcare. And we could do way better. You saw and heard some of the epidemiological data yesterday and also today with just the rate at which your community is affected by hypertension, diabetes, chronic kidney disease, dialysis, and your access to quality care and transplants. We could do better, and we at Ardelyx are taking a step to demand that we in fact do better. That's how I'd answer the question. Thank you for it.
Dr. Sanders, from a perspective of organized medicine, how does organized medicine impact what the individual physician is doing, but impact policy as far as healthcare is concerned? Where is that interplay, and how much weight does it actually carry?
Well, I think first of all, let me kind of step back. Organized medicine is really the collection of all physicians. I've been very active in the collection or organization of African American physicians known as the National Medical Association, but there's also the American Medical Association, which has historically been the collection of majority physicians. I could tell you that story, but I really don't have the time. But I do think that the important point here is that for things that are important to improved health outcomes, both of these organizations can advocate. I think if I use your word and we educate is the word I'm going to use, our elected officials to the importance of the decisions that they make related to specific issues. And although the AMA and the NMA may have differences on some issues, there are a number of issues where we find common ground, and those are areas where we need to work together or where we work together. And so I think to use your example, I think looking at a medicine and whether it's included in a bundle or outside of that bundle is something that we can work together on to advocate and educate our elected officials to help move that agenda forward. And I would actually pick up on the piece of Medicaid expansion. Although we may have very differences on Medicaid expansion, the National Medical Association supports Medicaid expansion in every state and will advocate and educate to make sure that we divide up the resources at the state level to make sure that we get as many people covered with Medicaid as possible, because it's important for all of us.
So how do we help the senator advancing this from our efforts in Senator? How do we help push that effort for expanded Medicaid, which is going to benefit a significant portion of our population?
First thing is go out and vote. It is important.
Would you say that again, please? I didn't quite hear you.
It is important to vote. It is important to vote not just in presidential elections, but your local. So that is again your state, your city, your school board, in a county. Is because who's elected will determine not just the makeup, at least at the state legislator, but really what policies you want, right? So due to some changes this year, due to gerrymandering, we actually now have a fair shot in the assembly where Democrats could potentially get the majority, which is huge. In the same breath, that doesn't mean that our work isn't done, right? And so when there are bills that are scheduled for committee, there's always strength in numbers. And so whether it's you calling your legislator saying, "Hey, this is my story. You know, this is why I'm supporting it, or this is why I want you to vote against it." If you send a written letter of testimony, if you can't come to committee, you can do that. Or if you show in person, that speaks volume. Is because those are the things that we're looking for. And, I know that there are different groups that, I can understand how intimidating it can be to speak in front of a lot of committee members, right? There are committee members that are friendly. And then there are some that, obviously don't want certain legislation to pass. And so it's important that you know who your allies are in the building. So that way, not only can you be best prepared to what you want to share, but also know that you have support there.
Pastor, the Church of God in Christ is very well organized. What efforts are you doing, speaking for the church, or should you be doing, push this health agenda further?
First and foremost, I want to give a disclaimer that says I am not speaking for our denomination. Just got to be clear with that sometimes. But I
Did not mean to put it
no,
quite
no,
that
no,
way.
no, I get it. But I believe that this is very important. The church has gone through many challenges over the past few years with the pandemic and all, and it's been very difficult to have people gather back together. But I think that even with the pandemic, us coming and being informed about things like this uh, can be very instrumental in our personal health and development. Had we known more about COVID, probably would have known how to address it and adapt to it when it came through on us like it did. And so, my initiative, my advocacy for this is for the people. It's for myself. As a pastor, we counsel a whole lot of things, and especially through sickness. And I believe I need to be able to tell them more than have faith in God.
Gotcha.
Um, Prayer does work, faith in God does work, but sometimes they want to hear what do I need to do because they're not hearing it from every level and every place that they go. And so I think that these type of initiatives is an added component to our counseling. And so that's my advocacy for it and why I'm such a strong believer in what we're doing today.
Where are we as far as cross denominations in the African church taken as a group? Is there enough coordinated activity, or are we missing opportunities to get these kinds of messages out?
I believe we're missing opportunities because our focus is not on the information getting to the people, it's resources getting in our pockets. And we have to go beyond what the benefit as leaders, as pastors, community leaders, we have to go beyond what's our benefit to what's the benefit to the people. I'm a firm believer you empower people. And when you empower people, people will empower the church because they'll know that what they benefited from, they'll know the origin of it.
Wow. Mr. Mosby, Honorable Mosby, former state representative Mosby.
Yes. All of
Not organizations such as HEAL, how does it impact policy and the health of Brother Dennis here?
So, and you heard Superintendent Fields talk about how it's important that the church is present in this particular part of the fight. Two things happen when you get the bad diagnosis. You call mama, or you call your pastor, or mama's gonna call pastor,
Mhm.
and somebody's gonna call, and the church is gonna be sitting there flat-footed with, I don't know what to do for you. Our organization, we are built to work with the church to say we're going to be the entity behind you to give you this information. And so you heard the doc talk about APOL1, which affects uh, many African Americans of Caribbean descent. That issue is something that we don't hear about globally, but we brought that through the church to bring that information to you. And so now you're not equipped to do something. The other thing is, if you're sick, I can do my ebonics. If you're sick, you don't work and you don't tithe. And the church then can't do the work that it's been called to do. And we are the arms and legs. So the Bible calls us the church. So it's not this building here. A lot of times we get caught up in this building. It is us. Our organization is about educating you all so that you can be better advocates. I don't know who you all know. So when I educate you, where you take it is going to exponentially uh, push information that we're doing here further out in the community. This issue that Ardelyx is pushing forward about changing what's happening in this bundle that happens when you get diagnosed with end-stage renal disease, and how medication, you get access to medication or not based on that dialysis center, is important for you to know that pieces of that. Now, you might agree with that or you might disagree with it, but how you make your voice heard in that process is why we are here today, to help you understand how to do that advocacy. That's what I hear.
I want the panel to think for a moment about your take-home message, your take-home call to action. And while you do that, we're going to listen to a greeting that we were able to have pre-recorded from State Representative Samba Balda. Do that.
Good morning. My name is Sambo Balde, State Representative for Assembly District 48. Thank you everyone for being here. Thank you to the Calgary District for hosting, and Hill Collaborative for coming to Milwaukee. Thank you to Matt Lars of Adelaide for reaching out. For everyone living with kidney disease or caring for someone with kidney disease, this is a profound challenge that people cannot imagine unless they have that experience. For example, what it means to organize life around dialysis. You should have the support of government at every level. You also know that kidney disease disproportionately affects Black Americans. We are 13% of the population, 35% of people with kidney failure, and 33% of dialysis patients. The kidneys are vulnerable to environmental toxins, and who is more likely to live and work in contaminated environments? Black people. We are only beginning to understand the very harmful effect of the PFAS group of chemicals on the kidneys and other organs. In my district, communities of color are more exposed, especially by consuming fish from polluted bodies of water. Kidney disease and environmental racism are connected. We also have to confront racism and unequal access to treatment in medicine. This work you are doing is extremely important. It cannot be left to chance. Reaching out to policymakers is essential. Thank you for your service.
That was a very interesting comment. Thank you. Let's begin with our call to action with Dr. Ozia.
I would say self-awareness, knowledge cannot be overemphasized. If you know, the better you can take care of yourself. Don't be afraid. I think I have a lot of people who, if you're told, when they're told they have kidney disease, they run away. they run away from the healthcare. That is not a good approach. Find a doctor you trust and learn more about the disease to take care of yourself. That would be my.
Thank you. Dan, start with you.
Yeah, I'll try to summarize it. I would say no and go. So get to know your healthcare providers, get to know your local elected officials that could influence policy. Go get screened for either chronic kidney disease. You'd be surprised as to the number of folks just in this room that likely have chronic kidney disease, either stage 1, 2, maybe even 3, that don't know it. Get screened for diabetes and get your blood pressure checked out. I wake up early every morning before my family does, and I often meditate and read. And this morning I read a great quote, and I know this could be difficult. Not everybody has access to excellent food and nutrition choices, but I read something this morning that I think is going to stick with me for a while. And especially given if you were here last night and you saw the number of pills that kidney patients have to take per day to control their kidney disease, it's fistfuls or hands full of pills. If you treat your food like medicine, it's probably wise. Otherwise, your food becomes medicine. So please, if you can, encourage people that you care about and please for yourselves, make good quality nutrition decisions and go get screened and go get to know your physicians. Thank you.
Dr. Sanders.
I would actually go to the research principle in clinical trials. Equip yourself with information about clinical trials. Be willing to participate. Don't get away from the idea that I don't want somebody doing research on me, but equip yourself with the information that you need to make informed decisions, because the benefit not only benefits you as an individual here now today, but it benefits our children, our grandchildren, and subsequently their children, because it's about working together to preserve health for everybody.
Mr. Mosley.
First of all, I'd like to thank Superintendent Shields for, again, opening up your house to allow us to be here today. This is Shields. I said Shields, didn't I? I'm trying to get to my point. Sorry.
Don't let him off the hook, please. You saw the way he treated me. Don't let him off the hook.
Now I lost my train of thought. No. I would like to thank Superintendent Fields for opening up his house to giving us this hospitality. We came here from the great state of Georgia to bring these programs, and we do them all over the country. And it is important that we have this advocacy. The thing that I would like to leave with each and every one of you, I asked Superintendent Fields today that what would it take? So if this is just a regular Saturday morning, those of you who are in this room are in here because you're supposed to be. But the room should be jam-packed. Why not? And it really is about, in our community, we need to advocate with our neighbors. You need to get this information. Don't let it get by you. This is Brett. If the church had to cost this out, that bring the experts that are in this room, you have a multi-billion-dollar corporation sitting here to bring this to the room. It will cost you tremendous amounts of money. We're bringing this by the grace of God to have you all have access to this information. Thank him too. I agree, but this has been huge. So please reach out, tell someone about this information, about this issue, about this bill, about everything that's happening here, so that this information gets out past us. So that's what I want to leave with you.
State Senator Drake.
We need political power and knowledge. When I say political power, we have an infrastructure that I think is broken. And when I say broken, it means that there's not the support needed to really move in the way that we can, right? whether that's engagement in the community. And I can be frank too, as elected officials, we can be better, trying to get the information out there and also communicating the need for how our elections impact what we're dealing with. I didn't share that I also serve as the chairwoman of the Legislative Black Caucus for our state of Wisconsin. And thank you. And I want to make sure I highlight the importance of elections is because in Wisconsin, unfortunately, diversity, equity, inclusion has been politicized in ways that it should have never been. And we saw that in the health committee this year, where any efforts that streamed or attempted to see how diversity impacts the quality of healthcare that people need and have it removed. And now we're seeing it play out at the national level. And we gotta be frank here, with Trump stating that there would be a potential, removal of any positions that are focused on DEI. That will have implications for what it means for clinical trials and in the healthcare facility. And so when it comes to knowledge, it's important on all of us to know what it means for our healthcare, the services that are presented to you. And it's also imperative that we do our knowledge when it comes to legislation and elections and know who we're voting for so we can either push an agenda forward or stop one that would do us more harm.
Before hearing from Superintendent Fields, I think we would like to thank the Calvary District Church of God in Christ, and in particular, St. Paul Church of God in Christ and their senior pastor for putting on a wonderful. We will, we will call upon the pastor for he gets his last word, and he'll also then close us out with prayer. And I will only want to admonish him that he is the only thing standing between us and lunch. So I want you to think about that while he's talking. Yes, sir. You had. Where do we go to find out? Where can we go and see the bills that are being submitted? Is there a site where we can go and find those things?
Yes, that's the state legislator website. So if you Google State of Wisconsin Legislator, that will be the website where you actually see all the elected officials throughout the whole state, all the committees, who the legislators are serving on those committees, and your elected officials as well. And I'll give my work email as well. It's rep.drake, DRAKE, at legis, LEGIS, .wisconsin.gov.
All yours.
Thank you all again for being here. I really am appreciative of having the opportunity to host this event. I want to take a moment. I know I am in the middle, but I must first of all acknowledge just a few people. I want to thank you, Mr. Mosby, for connecting with us. Thank you, Tanya Phillips. Why don't you just wave it as this woman of God has been a blessing. Gabby, there she is, Gabrielle Jones. Thank you so much. Dr. Wayne Tuckson. Dr. Lawrence Sanders, thank you so much. Steve Bird, where's Steve at? Oh, there he is. Thank you, Steve, the photographer. Wonderful job. Artilix is here. Thank you so much. I appreciate you. And thank you for your testimonial and for your kindness, even on yesterday, a conversation we had. Thank you so much for that. Also want to acknowledge Candace Nicholas, amen, who continue to share with us the updates on registrations and things of that nature. Shayla White, who kept Casey in line, our media person. Justice Mosley, who came through today and he's a great person in our community, and I was so glad that he was able to make it. Also want to thank Representative State Senator Dora Drake for coming. Let's thank God for her. with last minute. She just happened to be in attendance on Thursday night, and I encouraged her to come, and she showed up today. So we appreciate you. Can I say this? I have some friends here, and I wanted to just acknowledge how this session has been helpful. One of my good friends, we've been talking. He's been going through some challenges, just some changes in his body, and we were talking, trying to figure out what's going on, what's wrong, and of course the first instruction is go to the doctor. And as you all have stated, most of us don't really necessarily like going to the doctor, but hearing some information yesterday and today gave us a really keen and precise idea of what might be going on. And so now I think, if for nothing else, you've been very beneficial to us today and yesterday. Another thing, Dennis, Dennis has experienced a lot of health challenges in his time here, and we've been having to help push him through a lot of those challenges. Um, but what's crazy is that I never knew that the source of it was chronic kidney disease. I never knew that until he said it right there. I didn't know that that's what it was. I just knew the different things that he was experiencing in his body, all the health. I knew all of those, but I didn't know that this is what it stems from. And that's why, for me, it's important to know. All I all I ever said to him, it's been years, keep the faith. That's all I kept saying, keep the faith. But now I can say, what you been eating? Change your diet. I'm serious. I'm serious. I mean, sometimes you got to. Sometimes we have to. There's more than just the spiritual aspect of us. There's the natural side of us that needs somebody to talk to us naturally and say, you need to be better. You need to do something different. And so I'm grateful for another component to counseling God's people. All right, I just thought I'd share that. Lastly, I want to thank the hospitality. I want to thank the operations team that has helped. I want to thank the media and graphics. Casey is amazing. He and my son Jason came together and put together graphics and the media. Casey did all of this. He did all of this, all the connect, even with last minute changes because of individuals who couldn't come in. Casey did an amazing job. I want to thank my administrative assistant, Dion Wilson, I'm telling you, she is what was the seal? What was A though? Thank you. She did not let up on the team. She made sure we were on deck, and I mean antagonist in a good way. She stayed on us, wouldn't let us drop the ball, wouldn't let us rest until everything, even up until this morning. Hey, this is the last day. Get there. Make sure you're in place doing what you're supposed to do. So I want to thank God for you and your ability to coordinate and keep us together so that we would not drop the ball with this partnership. Lastly, I want to thank the Calvary District, uh, District Missionary, Dr. Orr McGahee, our District Missionary, to the pastors that participate. Pastor Ben Robinson is here today, Pastor Neil Kelly, all of the pastors that participated. And I want to thank all of you who thought it important enough to pause and come and get information. Because if I had to sum it up, I would take everything that we've all said and said, knowledge is power. And stop living without accessible power. Why would you live without power that's available to you? I'll preach right now. So I want to thank you all again. Thank you. I'm an advocate. I'm an advocate, and I am going to do all I can to ensure that this information goes forward. All minds and hearts are clear. Our God, our Father, we are thankful again for this time of sharing. We thank you for these who thought it not robbery to come and to share pertinent information that will be a benefit and not only ourselves, but to those that we are acquainted with. So, God, we pray for wisdom to apply the knowledge that we've obtained into the various areas of our lives, and that would help us to live healthy lifestyles, not momentary changes, but lifestyle changes that would be a betterment for all of our families and our communities. We pray to God now that you would bless the food that has been prepared, let it be nourishment to our bodies, take out any impurities, and let it be returned to you in service. These and other blessings we ask in your Son, Jesus' name. Thank God and amen. Thank you all again for coming. Yes, ma'am. Absolutely. It's on the church's platform, it's on Hill's platform, and we can go and just like it and share. As a matter of fact, I think everybody should leave and tag somebody. Go tag somebody and let them know that this information is available to them. Both yesterday's and today's information is available. Thank you again.
And please make sure you fill out the